All right, a couple quick slides on bipolar, focusing mostly on the management. Good thing is we've talked about pretty much all the drugs we use to treat bipolar. I mentioned this in depression, but bipolar can be difficult to diagnose, mostly because a lot of bipolar patients present with hypomanic symptoms as the manic phase of their bipolar disease. So they're going to be more commonly presenting and if reaching out for help or presenting to their psychiatrist or their general practitioner about depressive related symptoms, because that's going to be the one that they feel affects their daily living more so. Whereas their manic phase, they might actually feel like they're productive and they get stuff done and they feel good, they feel on top of the world. The problem is, again, I'll say this again because I think it's important to mention it multiple times, is that if you treat a bipolar patient simply with an antidepressant, you can induce manic phases. So somebody who's hypomanic might get more hypomanic, and ultimately they can end up with a full-on manic phase and be more likely to get a full-on manic phase if you're only treating the depressive side of their bipolar. So in some cases, you treat somebody for depression, you tease out that they're bipolar, and then ultimately they end up getting treated for the bipolar disease. But that can take some time to figure out specifically. So it's really important when you're treating mental illness, especially depression, to try and tease out those bipolar tendencies as well if you can. And that's going to direct your treatment slightly differently. So features of a bipolar patient: major depression with suicidal ideation behavior, similar to what we talked about with unipolar depression. Mania and hypomania are going to have to be something there as a qualifying aspect of bipolar. Mixed episodes would be a depressive and manic episode. And then some people might have psychosis components to it, and that's where things get confusing, I think. So there's a term called schizoaffective disorder, which is a little bit on the spectrum of schizophrenia, on the spectrum between schizophrenia and bipolar disease. So I like to think of it as schizoaffective is a bipolar patient who has psychotic features, or it's a schizophrenic patient who has bipolar features. However you want to look at it, it's basically a combination of the two illnesses. That's a simple way to look at it, and the DSM-5 would give you more criteria than that. That's basically it. So if you read schizoaffective, it's likely because they were maybe diagnosed with one of the diseases and then developed psychotic symptoms or developed something else or had them all together. So it's not uncommon for a person with bipolar, especially during a manic phase, to experience psychosis. All right, bipolar 1 is what you might think of as the hallmark bipolar disease. It's one or more manic or mixed episodes, with most patients having depression or hypomania too. So this is people who have full-on manic episodes and depressive episodes. Bipolar 2 doesn't have the full-on manic episodes or mixed episodes, but would have major depression plus hypomanic episodes. Cyclothymic or rapid cycling are people who have numerous periods of hypomanic and depressive symptoms. So they don't generally meet the full major depressive criteria, but they will have some depressive symptoms, and usually occurs over 2 or more years with symptom-free periods lasting more than 2 months. So it's a specific type of bipolar. And then you'll read sometimes bipolar NOS, or not otherwise specified, meaning it doesn't really fit any of those above criteria. So the whole point of all these names is that there's really not a specific, I mean, there are specific subtypes of bipolar, but some of them, some patients might just not meet any of these criteria. So if somebody's explaining to you symptoms and you're like, well, that doesn't meet rapid cycling, that's not really a mixed episode, but don't worry too much about that, because bipolar is pretty much all treated the same way, regardless of which area they fall in, which makes things a little easier. All right, mania. I think we know generally what mania is, or most people do. Elevated irritable mood lasting at least 1 week, grandiosity, lack of sleep, talkative buying sprees, hypersexuality, flighty ideas, goal-directed activity. Hypomania is a scaled back version of that, and it's usually shorter. So instead of a full week, you're looking at a few days, 4 days probably. And again, less intense, shorter duration. And the big thing about hypomanic phase is that social functioning is usually intact. People aren't missing work because of this. They feel highly functional. They feel like they're productive. 5 to 15% of people with a hypomanic episode could transition to full-on mania. So that's the risk there. Mixed episode is a full manic plus major depressive met within the same 7-day time period. So that's what I'm talking about when I talk about mixed episodes. Here's a diagram that shows the good times and the bad times. This is really dumb because, like, what's the point of this, right? This would be like for explaining this to a third grader. But you get the point, right? There's gradients here, and everyone has some fluctuation. So people do have tendency to fluctuate in mood. Sometimes we feel down, sometimes we feel great. It's common. That's what happens with everyone. It's just how do you diagnose those things that are pushing beyond those phases, right? So anyway. All right, goals of therapy. We want to restore the disruptive mood. So only 1 or 2 symptoms mildly persist, or complete resolution if possible. And certainly complete resolution of any psychotic symptoms is a requirement to be your goal. So you want to try and get rid of those first. Restore sleep patterns, which should help with energy levels, and empower patient to be functional socially and professionally. Episodes can usually be blunted, but difficult to eliminate altogether. And minimize hospitalizations. Lithium. So we talked about lithium very briefly in the last set of slides when we talked about clozapine. But what is lithium? Lithium is really just an element. Comes as lithium carbonate, comes as a couple other salt forms. Lithium carbonate's the most common one. And it's been used for over 70 years. It's a really old drug. And there's a lot of psychiatric conditions that lithium's been studied in and has been found effective. So lithium's a really common, not only medication for bipolar disorder, which is its hallmark treatment area, but also as an adjunct for depression. I showed that in the STAR-D trial, that was one of the tiers that you could go to as lithium plus an SSRI, and also as an adjunct to schizophrenia. So certainly can cross over into the other mental health diseases as well. It alters cation transport across cell membranes. Don't really know exactly how lithium works because it's just so simple. Lithium is very similar to sodium, so the channels it can interact with and block could be really diverse depending on where it's getting to the body, where it's getting in the body. But it's thought that there are some channels that it will work to influence the reuptake of serotonin and norepinephrine in nerve and muscle cells and in the central nervous system, of course. Postsynaptic dopamine inhibition as well. Intracellular secondary messenger systems that we don't fully understand. So lithium's got a lot of mechanisms. It's kind of a dirty drug from that standpoint, and interesting. It's one of those, like a lot of our really old drugs, no one could look at. No one, when they got this drug approved, could do like X-ray crystallography to figure out where lithium's interacting with. But we have theories, and there's been more research done, but still, it's not totally well understood. It's a really, really effective medication, but it has a very narrow therapeutic index. It's very easy to get toxic on lithium. It's one of the most effective medications also for treatment of acute mania. Somebody comes in a full-on manic phase, lithium's one of the drugs that can work very well. But it's also great as a long-term maintenance drug too. Interestingly enough, this will depend on the patient populations you see. So patients usually aren't started on lithium, even though I'm talking about how great it is, and mostly it's because of this narrow therapeutic index issue. I was talking to my aunt and uncle who are both PhD psychologists, and I was talking, when I first started working at Abbott, I'm like, yeah, there's a lot of people that take lithium. They're like, they still use lithium? I haven't seen lithium in years. Again, patient populations that have tried other things. I don't like to think of this as extreme as clozapine, but I do think it almost falls in that same. It's not treatment resistant per se, but because of its therapeutic index, I would be a little bit cautious to use it. However, it is very effective. So again, lithium carbonate, lithium citrate, here are the different salt formulations. Comes as extended release tablets, capsules. Usually it's dosed twice daily is what the most common I see it is. It does come as a liquid for patients as well. It's very well absorbed. It's widely distributed throughout the body as you might expect. It dissociates into its ionized form and goes all over the place. It's renally cleared, so it's got a half-life of about 18 to 24 hours. About 80% will end up being reabsorbed, which is why its half-life is so long. So it gets cleared like sodium, basically. Your kidneys are constantly clearing it and reabsorbing it. It just takes a long time for it all to leave out because so much is getting reabsorbed back into circulation. So that's why lithium does have a long half-life. Drug and food interactions. Anything that interferes with renal clearance is problematic. So patients who are on diuretics, ACEs and ARBs, and NSAIDs all should be cautioned. So actually, we recommend not using NSAIDs at all with lithium. And not because people are likely to get major toxicity with it, but because we don't really know how far out of that therapeutic range we can tolerate somebody getting. So for the most part, if you can remove something that is possible to interfere with lithium, it's best to do that. And these are the drugs that are the major culprits. Salt intake also can be substantially affect the way lithium's reabsorbed through the kidneys and excreted through the kidneys. So that's something. And hydration status. You can dilute out lithium by drinking a ton of water. I talked to a young woman once. I used to do this when I used to work in mental health. I used to do these medication education classes. And I talked to a young woman who's like, "Oh, I do hot yoga, and I just got started on lithium. What do you think about that?" I'm like, "Those two things probably not compatible." I'm like, you can talk to your psychiatrist a little bit more about that, but the fluid losses and then the rehydration, it just might be too much concentration and dilution over a short period of time. It might be okay, certainly, but I would be cautious with anything like that. Certainly people can exercise and sweat and type of stuff, but I think fluid balance is really important. So if you have somebody who is exercising a lot or losing a lot of fluids in short periods of time, making sure that they're replenishing continuously so that they aren't getting fluid down or dehydrated. It's very important with lithium. You get dehydrated, it concentrates, and all of a sudden you've got toxicity, even though you didn't take any extra drug. So it's a balancing act when it comes to fluid status. All right, lithium also has indications, kind of like clozapine, where it does reduce the risk of suicide. It's effective, again, for manic episodes. Side effects: polyuria, thirst, weight gain. Polyuria and thirst, kind of like what you might think about if you consume a lot of sodium, not too much different there. Weight gain and cognitive impairment are some of the things that you see crossing over into the long-term mental health component of it, and why it's causing weight gain I'm not sure, and cognitive impairment tends just to cause some cognitive slowing in some patients, but a lot of patients do tolerate it pretty well. And you can maybe make an argument that cognitive impairment might happen when you see lithium get pushed a little bit high on its therapeutic index range. But chronic toxicity, you're looking at, cognitive impairment meaning an initial side effect, and also likely to improve over time. What I understand is lithium gets distributed throughout the body and your body gets used to it. That might go away. And the weight gain might be initial, but again, not sustained. Chronically, renal failure. This is a controversial thing. Is lithium renally toxic? Some people say yes, some people say no. There's some case reports that show that it causes kidney toxicity. The bottom line is if you have any type of renal failure on board, lithium will increase in its blood concentration. So it's difficult to say if somebody's on lithium, yeah, if they're in acute kidney injury, their lithium level is probably going to be elevated, but is that what caused the acute kidney injury? You have to rule out other things. I think there's some evidence that says maybe it does, but I don't necessarily believe that it's a huge contributor to nephrotoxicity. However, if you did have AKI and no real other obvious source, I would say maybe hold the lithium while it resolves. Thyroid may cause goiter or inhibition of TSH receptor. There's some interaction with the TSH receptor and about 15% chance on long-term therapy. It is pregnancy category D. I have seen people on it during pregnancy, rarely, who have been on it for years, but it isn't the greatest drug in pregnancy. All right, so I talked about narrow therapeutic index. I'm not going to ask you about blood levels or anything like that, other than knowing that we do monitor lithium blood levels. So there's some specific targets. So during mania, you're looking at targeting a 0.6 to 1.2, so a little bit higher level in mania than for maintenance. But also with maintenance therapy, we don't want to get below 0.8. So this is a really tight range to target. It's very difficult to keep somebody in this range consistently, but that's, again, very narrow therapeutic, meaning that you have to get it up there to have any effect. And then if you go over a little bit, but you do have some wiggle room on the end. So usually you're looking up to 1.5 to 2. That gives you GI issues, tremor. 2 to 2.5, confusion, somnolence. Greater than 2.5 would be seizures or death. So seizures are the big thing that people are going to see. If you work in ER and you see somebody come in on a lithium overdose, that's the thing that's going to happen. Basically, for treatment, this is a very treatable overdose. You're looking, or a treatable toxicity. So even if you get somebody who's in this range, if you just IV hydrate somebody, unless they're contraindicated, like a CHF patient who's fluid overloaded, which they probably wouldn't be on lithium anyway if they're CHF, but you can just IV hydrate them. That dilutes it out. That helps with the symptoms. That can help with some of these early symptoms if they're just mildly toxic, like up to 2.5. If anyone's greater than 2.5 and symptomatic, or greater than 4 at all, regardless of symptoms, you dialyze them. And lithium can dialyze off very easily. So you can get them to emergent dialysis and pretty much solve the problem that way. So lithium's not that difficult to treat. You just have to have access to IV hydration in a dialysis center. All right, anticonvulsants. Also good options. These drugs have been sort of relabeled for the purposes of bipolar use as mood stabilizers. So mood stabilizers are thought to be basically the following anti-epileptic drugs are used as mood stabilizers. Valproic acid has been the one that's probably been used the longest, and it's the only AED effective for acute mania. So we really only have two drugs that will affect an acute manic episode, and that's lithium and anti-epileptic drugs. Now, we haven't talked about the psychotic components that can happen during acute manic episodes, which we'll get to here in a second. In that case, you'd switch gears a little bit to an antipsychotic. But for acute manic episode without psychosis, lithium and valproic acid are your two drugs of choice to start somebody on. Other drugs that people get maintained on for bipolar type 2 very commonly would be carbamazepine or bipolar 1, or really any bipolar. I should delete this type 2 because that's not exclusively true. Generally speaking, bipolar type 1, you're going to see people more commonly on lithium or valproic acid, but for all bipolar, you could really use anything technically. Carbamazepine, lamotrigine, topiramate, and gabapentin/tiagabine have all been studied and used for bipolar disease. One thing to think about with some of these drugs, first of all, none of these four are approved for acute mania. So in the acute phase of the disease, it's not going to be all that effective. Lamotrigine requires a massive ramp up, remember? So it's hard to get somebody onto lamotrigine because it takes a while to get to a therapeutic dose. So that can be a limiting factor. But some other anti-epileptic drugs have been studied, but these are the ones that are commonly used. Probably the ones I see the most are valproic acid, lithium, and lamotrigine. I don't see the other ones quite as commonly. Gabapentin's used a lot as an adjunct for a variety of mental health illnesses, so kind of hard to determine what exactly they're using it for. Antipsychotics. So acute mania has a psychosis component sometimes, and so in combination with your lithium or Depakote, a lot of times you can use an antipsychotic. Now, if somebody's hypomanic, you can give an antipsychotic as well, even though there's no psychosis. So this is where it gets confusing. Certainly, if there's psychotic elements, you want to treat it with an antipsychotic. However, there's been a lot of decent research into using second-generation antipsychotics first line for hypomanic episodes in bipolar patients, and that it actually works quite well. So all the drugs we just talked about are anticonvulsants, or aka mood stabilizers, and lithium. Maybe we just throw them out the window and go with the second-generation antipsychotic. That's a little bit of the school of thought now, especially for hypomanic and bipolar type 2 patients. But doesn't mean you couldn't use a mood stabilizer if you wanted to. So first-generation options, acute mania, probably going to look at haloperidol or another potent first-generation, or something like olanzapine. Get those psychotic components controlled fast while you're working on the manic phase with a lithium or a Depakote. Once things are resolved, you can decide, okay, how's the patient doing on lithium or Depakote? Do I want to keep them on it? Or maybe I want to transition them to something else. Maybe you keep the lithium going, but you start ramping up lamotrigine, and then you switch them over if you don't think the patient will be a long-term good candidate for lithium. So that's a strategy that's employed sometimes, is these acute medications, including the antipsychotics, might be a bridge to a later therapy in one of the other medications, specifically lamotrigine, because it's generally very well tolerated. Other maintenance options approved and studied: asenapine, lurasidone, paliperidone. All the basically second-generation antipsychotics are pretty much fair game for a bipolar patient. Okay, so let's talk about this and review a little bit. Acute mania, acutely manic initial episode, lithium or valproic acid, plus your haloperidol or second-generation antipsychotic if psychosis elements present. Okay, so that's the important thing too. You don't have to treat somebody with a antipsychotic initially for a manic episode. In fact, you probably should just stick to lithium or valproic acid. But if they do have those psychotic elements, you're going to use both. If you're hypomanic, evidence shows that your preferred drugs should be risperidone or olanzapine. Have been well studied in hypomanic. So if somebody prevents acutely hypomanic's a bit, I don't know, it's not necessarily, I don't know if it's the most correct term, because is hypomanic ever acute? But the idea is that it's a sudden onset, the person's aware of it, and they're presenting to emergency department being like, I feel different, I don't know, I have my history of mental health in my family, I'm afraid I'm bipolar, yada, 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 and they end up presenting with a hypomanic phase. Anyway, second-generation antipsychotics are thought to be preferred in these cases, even though there's no psychosis. So that's, again, where it gets a little confusing. Alternatives: lithium, valproic acid, other second-generation antipsychotics, possibly haloperidol, but for the most part, you're going to use. So you can, if you want to simplify it, you can use these drugs for your hypomanic stage, but current school of thought would say for hypomania, lithium valproic acid, a little bit more difficult to titrate, more narrow therapeutic index, more side effects. Acutely, if you're using risperidone or olanzapine, the side effect profiles are relatively good. Now, chronic olanzapine, weight gain is not something we like, but generally for an acute phase, it's not going to be all that troublesome for most people. 2 to 3 weeks and suboptimal response. Switch lithium for valproic acid or vice versa. Add lithium or valproic acid if hypomanic. So if you started on risperidone, you're going to want to add one of these. Continue the process until something works. Now, generally speaking, 2 to 3 weeks, they should be out of their acute phase. But you definitely want to get them controlled. They could easily swing back into an acute phase during those 2 to 3 weeks too. So that's what we're trying to do, is to break that cycle of the acute mania and the depressive episodes. All right, so let's talk about maintenance. First line monotherapy: lithium, valproic acid, lamotrigine, risperidone. IM actually is kind of the one that people prefer in this, and I think I don't know if it is studied that way specifically, but that's one of the recommendations out there, to do the IM. And I don't know, there's not really a downside to it other than the cost. So that's the question. And you have to start somebody on oral risperidone first before. So let's go back to this other slide. So let's say in the acute phase, you're treating them with risperidone for a hypomanic episode. They respond well to it, they're tolerating it well, and let's say, okay, well, let's do a long-acting injection. Especially if your person is, I'll say, clarify this with plus minus IM. So you don't have to do IM. I think IM would be ideal in a person who's non-adherent. And again, you have to make sure they're going to respond to the risperidone before you do a long-acting injection. Second line, aripiprazole, quetiapine, olanzapine would all be ones that you can consider second line. At 4 weeks, suboptimal response. Usually you're just looking at combining your two categories. So maintenance could be either second generation antipsychotic or mood stabilizer, and then your combination is going to be your mood stabilizer plus your SGA, or lithium plus your mood stabilizer. So lithium, so think about this as 3 categories. You got lithium, you got mood stabilizers, aka anti-epileptic drugs, or second generation antipsychotics. So, or you could be on all 3, right? So you could be on lithium plus AED plus SGA. And you could theoretically be in a situation like that too, but hopefully one of these combinations would work. So all of them are approved, all of them are acceptable, all of them are used. So it's really a matter of how the patient's responding. It's going to be a matter of how the psychiatrist is comfortable with prescribing it, and if they have specific drugs they like better. But there are certain indications that you're going to go with one or the other, and that's going to be mostly acute. When it comes to monotherapy, again, if they responded well during the acute phase and they aren't having side effects to the medication, yeah, maybe keep it on. But maybe you're like, well, I've had really good luck with lamotrigine long term, so maybe that's the drug you choose to go to. Or you say, well, I've had great with hypomanic patients or bipolar type 2 patients. Aripiprazole has been working wonders for them. Maybe that's the one you go with. So again, a lot of this can come down to what your provider preference is, or what your personal preference is based on the history and what you've experienced clinically. Now, studies are out there and there's evidence to support some of this stuff, but it's not robust. There's small trials and there's not a lot of head-to-head stuff comparing things. So you might find some little bits of 50 to 100 patient trials here or there, but ultimately there aren't these aren't big trials that they need to do to make money. So a lot of times it's sort of up in the air for what you're looking at, but this is generally the strategy you could approach. All right, that's bipolar.